Hello, everyone. This is Damon Scales from the University of Toronto in Toronto, Canada. My talk today is called Treating Sepsis in the Pre-Hospital Setting. I'd like to start by thanking the organizers of the conference for inviting me to give this talk. I do have a conflict of interest to declare. This is that I hold an operating grant to study this topic with a randomized controlled trial of pre-hospital sepsis treatment called Pit Stop. I have no other conflicts to declare. In this talk, I'm going to briefly discuss the rationale for earlier identification and treatment of sepsis, discuss the challenges with pre-hospital identification, and talk about some opportunities for pre-hospital treatment. Why would we care about this? Well, there's lots of good examples of other critical illnesses that we just take for granted that earlier identification and treatment in the pre-hospital setting can lead to better outcomes. Code STEMIs, cardiac arrest protocols. We have regional trauma programs that bring people from the pre-hospital setting to trauma centers and code stroke programs. Why not a code sepsis that would take the same focus and try to identify and treat people in the pre-hospital setting? The idea here, of course, would be that earlier treatment can potentially mitigate the organ dysfunction that's caused by the dysregulated host response to infection and potentially lead to better outcomes, including lower death rates. It's an appealing problem to study because it's certainly a common issue identified by paramedics. This is data from King County in Seattle, American data, showing that the incidence of sepsis transported by paramedics continues to increase over time and is actually much more frequent than paramedic-transported heart attacks or strokes, with a much higher mortality, about 20% hospital mortality amongst these patients, which is about double what we see for a code STEMI or code MI. I think that the proof of concept about early recognition and treatment should be easy to sell. The Rivers trial, I think, has had lots of different interpretations, but I think one common takeaway point is that the earlier treatment of these patients with the protocolized approach and early treatment led to a considerable reduction in their mortality. Are there data showing that earlier antibiotics in patients with sepsis is helpful? You would think this would be common sense. Well, it certainly has been well described in mice. This is a nice study from Anand Kumar, who used a mouse model of severe sepsis, showing that if there is no delay to the administration of antibiotics, survival rates for these mice is about the same as the sham uninfected mice. And there certainly is a time signal here where the earlier antibiotics were delivered, the more striking the survival benefit in mice. The best human data arguably comes also from Anand Kumar's group using an adjudicated sepsis database. They looked at survival rates depending on time to antibiotics after the onset of hypotension, and a very striking signal here. If antibiotics were delivered within the first hour of hypotension, 80% of the cohort survived, and each hour decreased the absolute survival by 8%. By the time a patient had a 6-hour delay, which incidentally was the median time to antibiotics in this cohort, mortality had dropped to 50%. The signal was so striking they had to graph this on a logarithmic scale, just showing that, at least in this cohort, very striking signal that time to antibiotics really matters. Other compelling data come from Chris Seymour's study published in the New England Journal of Medicine, where they analyzed the results of a statewide initiative in New York to improve the adherence to so-called sepsis bundles. In this study, again, a time to antibiotic association here. The sooner people received antibiotics, the lower the odds ratio for death. Interestingly, and I'll come back to this later, no signal here for a mortality relationship with an initial bolus of intravenous fluids. The conceptual framework here is nicely discussed by Chris Seymour, and he makes the point in this article that we really can't do anything about patient delays except for raising awareness about the importance of sepsis. But there's a lot of system delays that can interfere with the ability of our patients to receive much needed therapy. And the idea of identifying and treating patients in the pre-hospital setting is very appealing to try to overcome some of these system delays described in this slide. And certainly delays to antibiotics are very common. Again, data from Chris Seymour showing real-world information from Pennsylvania, a large network of paramedic services, showing that when paramedics do transport patients to hospital, they have a very high mortality risk, approaching 11%. But the median time from first contact by paramedics to first dose of antibiotics was more than 4 hours in this study. This delay was comprised of pre-hospital and emergency department delays, but certainly lots of potential for system-level improvement in providing earlier therapy if we could get our paramedics to participate in the identification of these patients. So how do we do this? Well, we certainly need sensitive tools to diagnose infection and sepsis. And I'd point out that most paramedic systems lack many of the diagnostic tests that we take for granted in the hospital. They don't have access to radiology or blood work or other testing that might help them make the diagnosis of infection or sepsis. And we also need effective treatments. I've been discussing antibiotics, but other treatments that can alter illness trajectory if these patients are identified earlier. How might paramedics identify sepsis? Well, the NICE Sepsis 3 document gives us some very good recommendations, but I'd argue that using the SOFA in the pre-hospital setting is just too complicated because they lack access typically to many of the variables that are included in this score. This document recommends using Q-SOFA, which is very simple, easy to calculate, easy to measure, certainly appealing. But a challenge here is that this is helpful for identifying sepsis when infection is already suspected, but it's not helpful for a paramedic to identify infection. So as a first step, we need a strategy to help paramedics to quickly identify infection. It turns out that probably, back to basics, regular vital signs are probably the best way to discriminate. This is nice data from Dan Lane, who used an entire province of data from Alberta looking at emergency transported sepsis patients. And he showed a very striking relationship with temperature. The probability of diagnosing an infection goes up dramatically as temperature is elevated. Maybe not surprisingly, the other vital signs are not helpful for identifying infection. And interestingly, when applied a different way, you can see temperature on the x-axis here, a very striking relationship between temperature and infection, but not so much for sepsis. So we propose a two-step strategy, which again is supported by the Sepsis 3 framework. First, identify infection with a fever, and then among patients who have an infection, yes, these other vital sign abnormalities that are really markers of organ dysfunction become helpful. And of course, in this slide, I'm showing you the components of the Q-SOFA. Dan Lane went on to compare different available scoring systems for use in the pre-hospital setting. There's been several published. The CIP, the NEWS, and the HUES all perform very well, but they're also much more complicated scores compared to the Q-SOFA, which again is just so appealing because it's easy to calculate and comprised of just a limited number of points. In the future, it's likely we'll think about using biomarkers and point of care testing. Nice work from Emily Brandt in these two studies showing that if you use biomarkers collected in the pre-hospital setting to augment other predictors of infection and sepsis, you can improve your accuracy. Where I work, these aren't ready for prime time, but certainly in the future, we may be complementing the paramedics' arsenal with these biomarkers at the point of first contact. Can early identification actually lead to a change in outcome? This is, again, nice data from Dan Lane that evaluated the impact of fluid bolus in the pre-hospital setting on outcomes of patients who are transported with sepsis by paramedics. You can see that, not surprisingly, patients were more likely to have received a fluid bolus if they had a lower MAP, and they were also more likely to have received a fluid bolus if the paramedic actually thought that sepsis might be the underlying problem here. In the time of transport, the average amount of fluid delivered by a fluid bolus in this real-world data was about half a liter, 500 milliliters, and this didn't seem to lead to an appreciable delay in transport times across these different categories of patients. Another association observed in this study was that among patients who received a fluid bolus, they, perhaps not surprisingly, were the sicker patients with a higher in-hospital mortality. But perhaps the most impressive findings were that there did seem to be an interaction between initial blood pressure and the likelihood of having a good outcome with a fluid bolus. So among patients who received a fluid bolus, the risk of dying was lower if the fluid bolus was given when the initial blood pressure was low. But in fact, there was a signal to harm if the fluid bolus was given to someone who was not overtly hypotensive, and that's shown again on this slide. And this, I think, is an argument for a more personalized approach rather than a one-size-fits-all approach to fluid resuscitation in patients with sepsis. This is to date the best study to evaluate pre-hospital intervention, a really wonderful undertaking from the Netherlands, where they randomized patients identified by paramedics as having suspected infection, a fever, and at least one other SIRS criterion, and they gave them 2 grams of intravenous ceftriaxone. Disappointingly, there was no change in 28-day mortality, but I think that my own impression here is that the time to antibiotics in the emergency departments in the Netherlands are certainly shorter than they are in my own health system. And I also worry that because of the inclusion criteria, the cohort in this study was less sick than we might have wanted to target for this intervention, with only with very few patients actually having septic shock. We're attempting to study this in Canada, a very similar question, but it'll be a factorial randomized trial studying antibiotics versus placebo and standard IV fluids versus a more aggressive fluid resuscitation. The trial is underway. Very simple inclusion criteria: suspected infection, fever, and hypotension. And again, this factorial randomization. I think what's unique about our study is that we're asking the paramedics to give intramuscular ceftriaxone. Thinking about those systems delays, this is a very appealing intervention because intramuscular antibiotics will start working the instant that they're injected into the patient, overcoming, again, potentially overcoming the system delays. Our primary outcomes are mortality at hospital discharge in this study, but I want to highlight that although it may seem like a common sense approach to have paramedics initiate therapy early, there's lots of potential unintended consequences, especially considering that they don't have the same diagnostic arsenal that we have in hospital. They may be providing the wrong antibiotic given the bug, and so it does warrant further study. In conclusion, I think there's several system barriers that may delay the delivery of time-sensitive sepsis treatments, and pre-hospital identification and treatment is an opportunity for us to improve outcomes for these patients. But first, we need strategies to identify infection. Temperature may still be the most helpful available measures to paramedics. And among those with infection, of course, the simple QSOFA is a very plunky tool that is a very plucky tool that's very helpful and practical. We do have an obligation to study more and watch this space. We hope to have the results of our study in the next year or two. Thank you again for the invitation to speak, and I look forward to the rest of the conference.